Saying that, then obviously 50% are younger than that, and that is actually the ballpark average for all cancer diagnoses, given that children have cancers as well as adults, but that is the average. There is an increase in the number of people with myeloma, quite alarmingly actually, but that's an increase in the number of all the people, and that is explained not because we're seeing more myeloma, but there's an aging of the population generally. Therefore, it's not difficult to understand that you're going to have diseases that affect those age groups increasing exponentially. I was doing the statistics for how many people we diagnose in Australia every year, and these are the official statistics, so they're always a little bit behind. And they are quite similar. I was quite surprised at quite a low population you have in New Zealand. So I looked at these figures and I thought, gosh, there's not a lot of myeloma in New Zealand. And then I realised there's actually not a lot of people in New Zealand. So that is pretty relative. And around the globe, the incidence is pretty similar around the Western, the incidence in America and Europe, etc., is relatively similar. Yes?
Is it still a bit vague about what causes it? The bits I've read?
Yes, a good question. This gentleman asked what may cause myeloma, and I didn't include data on that just for timing, but we don't know of one particular cause. It is likely, and there is a lot of research ongoing for all diseases to try and ascertain any particular causes for any disease so that we can educate society so they can choose to avoid that or not. In terms of myeloma, it seems that there are certain things. Being exposed to petrochemicals over a long period of time may not be a good thing, and there are increased incidents. It is difficult also when you do have a relatively rare cancer. You've got low figures and low numbers. So when it comes to interpreting cause and effect, it can be tricky with very small figures. There are some papers that actually do refute that link as well. But that is thought to be, being exposed to a lot of nasty chemicals over a long period of time is probably not a good thing. There has been increased incidence of blood cancers, including myeloma, in populations such as firefighters that are exposed to a lot of nasty chemicals. There was a spike after 9/11, unfortunately, with lymphomas particularly, people that were exposed around that. There were some spikes in some populations in the farming industry. We think perhaps that they may with better improvements in health and safety and less exposure to chemicals, and I know farmers used to sort of jump in with the sheep as well, and perhaps they don't do that these days, that we may see that association not there. Exposure to very high dose radiation, so if people had been working in the industry with radiation, perhaps in the forces that were exposed to radiation, there is an increased risk of cancers there, including myeloma. There is increasingly a link to cancers, including myeloma, in populations that are obese. So that tells us that maintaining a good healthy weight is a general health thing to do. And in terms of other populations, I did read at IMW actually that certain healthcare workers, including nurses, Amy and Rebecca, may well be at increased risk of myeloma and other cancers. But there is no definitive risk. There is nothing we can say to say that you got myeloma because of this that happened in your history. But there's ongoing work. Yeah.
That meat eating was a risk factor.
The what, sorry?
Eating meat was a risk factor.
Eating meat is a risk factor to myeloma. It's not, no. And I actually heard a talk. There was a guy who works in statistics in cancer services in Victoria, and he did a great talk to some medical colleagues, and his sort of take-home message was you can enjoy a nice steak and a Shiraz because of all the things we do know, they're definitely not linked to myeloma, and nor is smoking. So he had this picture of meat, a glass of wine and a cigarette. But you kind of need to choose your poison, don't you? Because clearly a lot of red meat is actually linked to certain bowel cancers, and wine has potential health properties in some ways and not in others, and smoking clearly is linked to many cancers. So I certainly hadn't heard that red meat was linked to myeloma.
It's not a problem for us now anyway.
No, because you have myeloma, yes.
So I owe it anyway.
Yes, yes. But it is nice, it is important to know, and research is ongoing, because if we do find factors that are linked to why somebody may have myeloma, then obviously we can educate the population and those generations behind us to avoid those. That doesn't always work, because we know quite clearly that smoking is linked to many diseases and people still choose to do that. So in terms of moving on, and just a few slides looking at treatment, the focus of this session is not to sort of focus on treatment too much, but as I said, I'm happy to take questions. In terms of new directions of treatment, you may well know, I'm sure, that myeloma is not a cancer that we can cure, but it is a cancer that is increasingly treatable. And it is said again and again in the literature that of all the cancers, all 140 of them, things are moving faster within the field of multiple myeloma than the majority of other cancers. And that's a good place for researchers and clinicians to be. It's a good place for you to be also, because there's a lot of hope and a lot of positivity around how best to manage this disease. But there's also a lot of uncertainty, because when we're describing a likely pathway of treatment for a patient, we don't know. We can't plan that pathway too far ahead, because we just don't know what the evidence and the research will tell us as to what might be the best treatment in 2 or 3 years' time. But things are moving very fast, and that was evident in the conference I attended in Paris. Some of the themes behind how things are changing and how we manage myeloma are based upon our increased understanding of why multiple myeloma forms in the first place, and the specifics at a sort of molecular and genetic level. And those of you that do a lot of reading around this area may have read that they have actually done, researchers have performed some large sequencing of myeloma genome in patients, and that was just published this year. And that really is going to be a platform for researchers to find even newer and more targets to treat and for therapies and active treatments against this disease. And the genome is really our sort of genetic map. Each of us have a different genome. There's not one genome, but if we can understand the genetic map of somebody that has myeloma, including some of these mutations or alterations that happen within the cells that gives rise to a plasma cell being a healthy plasma cell to it forming into a myeloma cell or an unhealthy cell, then that may well in time provide us targets to actually turn those mutations off, or to find therapies that can bypass those mutations and allow these plasma cells, these myeloma cells, to die. So that's a very important bit of research that has really become coming into the literature in the last year. And we will see in future conferences progress that has been made and built upon that. In terms of increasing number of treatments, I've been working in the field specifically of multiple myeloma for about 15 years. And when I first started in this field, we only just had thalidomide licensed. We basically had melphalan and prednisolone, and then we were hearing about this new drug thalidomide, which I believe New Zealand actually got first. So you were ahead of the whole world in getting that license, so well done. And now we have thalidomide plus son of thalidomide plus the next son of thalidomide and a whole range of other agents in that family. We also have other families of drugs such as Velcade or bortezomib. It's the same thing. Again, another example of confusing you by calling things two names. And that's another family of drugs, of which there are several generations of those coming through into the clinical setting. We also have a greater understanding of how we can use these drugs in combination. So, for example, data was presented at the conference. If one drug has stopped working for an individual, if you actually add another drug to the cocktail, you can make that initial drug start working again. So, better understanding of how to use these new drugs and in what combinations. And also a greater understanding that myeloma is a very individual disease. All of you in this room probably come to a diagnosis of myeloma and have certain complications and problems that are quite different to each other. Just for a bit of show of hands, I mean, we had a show of hands, who presented with a bone problem at diagnosis, pain or a fracture? Some hands going up, yes. So that's a good few of you, but then some obviously didn't. Who has had problems with their kidneys? One gentleman here, yeah. So that's something that is unique to the way your disease behaves. And this gentleman, who has a lot of immune problems with their myeloma, perhaps always getting a lot of pneumonias or infections and things like that. gentlemen, gosh, you're a healthy bunch of patients with myeloma, aren't you? Goodness. Yes, but it really is a very individual disease in how it presents, how it affects each of you, how you respond to one treatment and perhaps not another, how easily your disease goes into a period of remission or plateau or not. And clinicians are learning that perhaps there are different ways of managing and treating different types of myeloma. And again, the differences in the types of myeloma are probably based at a genetic level. And some of you may well actually have some tests on your bone marrow or your blood that are looking at what genetic abnormalities you may have that are unique to you. And does that test and that genetic mutation that occurs at the time of your disease, which is different to inherited genetics, does that help us decide whether you should have treatment A or B or C, or whether you're going to actually respond better to treatment A, B or C? So these are approaches by which in time there will be probably a clinician that will diagnose a myeloma patient, tap in all the specifics of their particular disease and how their myeloma affects them, and out will pop the best treatment for that patient. And I don't think we're that far away from being able to do that. In terms of aims of treatment, I did mention that myeloma is not a curable disease. It's not something we need to say, right, you need to have treatment A and we hope to cure your cancer, but it is an increasingly treatable disease. And the aim of treating myeloma is to gain control, to put your disease into a period of a form of remission, or if not complete remission, then into a form of stable disease where it is not affecting your ability to function, and to keep it away as long as possible, and then to have a plan for when it comes back to treat you with another course of treatment, and to do that over increasing lengths of time. We also need to reduce any existing symptoms you may well have at diagnosis. So if somebody's presented with bony problems, we need to be able to fix that, or certainly reduce the pain and fix any areas of damaged bone. Or if the kidneys aren't working, we need to be able to deal with that and either get them back working again or to minimize the risk of further damage. We need to be looking after the bones, the kidneys and the immune system, and we're going to talk about that further, and to maximize your quality of life, to allow you to sort of put myeloma for periods of time on the back burner and to be able to get on with things you enjoy doing. Therapy is increasingly risk adapted for the individual. My 28-year-old patient who was diagnosed last year with myeloma may well actually have a different treatment plan to my 92-year-old lady with myeloma, who we wouldn't recommend the same treatment plan for. So increasingly individual. The choice of who has what treatment when and in what order is increasingly more tricky, in my opinion, as we have more treatment options. What we need to take into account is the stage of your disease, how much myeloma you have around. Do indeed you need to start having treatment yet? When to jump in with the next course of treatment? We need to take into account what agents we can get our hands on. Is there a clinical trial that may be suitable for you to participate in? And the general health and fitness of the patient sitting in front of us. And of course, patient choice. When we do have certain treatment options and we start to run through those options with a patient, patients will quite rightly accept different risk definitions than we will, and some patients, particularly if they're on the cusp of having high dose treatment or not, may go away and have a chat with some other patients that have been there and come back and say, you know what, that's not for me, I'd rather not have that, can you come up with plan B? So patient choice comes into it as well. The backbone of treatment for myeloma, as you all very well know, is made up of a range of different agents, some chemotherapy agents, most commonly 2 drugs, one called melphalan and one called cyclophosphamide. Then in combination with the steroid, which I know you enjoy so much, yes, some grins looking at me, and the 2 common ones we use are listed there. Then the family of what we call immune modulators, which is thalidomide and Revlimid, and there's a new one of those called pomalidomide, which is coming through, and some other coming not far behind that. And then another class of drugs called proteasome inhibitors, which cause myeloma cells to die off in a slightly different way. And Velcade or bortezomib, it's the same drug, is the first in the line of proteasome inhibitors that are coming through. But there are others coming through in clinical trials very, very soon.